the satellite dish externally, what we call the pinna, all the way up to the outer membrane of the eardrum. If you have otitis media relates to the middle ear, so the middle ear cavity behind the eardrum. The patient does suffer from chronic ear infections. They had one a few months ago, which was treated by their GP with antibiotic spray. However, it is chronic and it's returned. And part of that, I feel, is because the patient's been getting water in the ear. So after the procedure, we have referred back to their GP so they can get a repeat prescription for some more antibiotics to help with this infection. But I've given them some advice regarding their ears, which they weren't aware of before. And the main advice is to avoid water entering the ear. Water can, of course, swimmer's ear and lead to an ear infection. So a lot of this infected debris was quite medially impacted right up against the eardrum. So I've cleared the debris. However, there's a thin slither of dead infected skin on the eardrum there, and we're now going to gently remove this. And I'm using a fine end suction probe. I'm just approaching the posterior section of the eardrum, so this is the back part of the eardrum. And I'm just gently peeling it forward, so we're trying to take it off the eardrum. There's very little space to work. You can see the suction probe came quite close to the anterior canal wall, so the right-hand side of the ear canal. And because we're on the inner 2/3, it's a sensitive region, the bony part, so we're going to be really careful. So to mitigate the risk of bumping into the ear canal, you may be able to see that the suction probe, I've bent it slightly on the distal region, so that when we say distal, we mean near the tip. If it is closer to us, we call that proximal. And I'm now just hovering over, we're in the anterior recess, you can see I'm just redrew the suction probe slightly because I was getting a bit close to the anterior canal wall. And it's just a little bit more skin. This is a bit more strongly adhered attached, but it does eventually come off. There we are. So the eardrum's fully visible now, and I'm just going to hover over the ear canal just to suction any remnants, any thicker layer of discharge. Now, because we're on the cartilaginous portion here, the rules of the game change a bit. We can apply a bit of pressure to the canal. It's still going to be gentle, of course, but the outer third of the ear canal is cartilaginous, so we can put a bit of pressure. And you can see the difference now from when we started. The patient felt really over the moon. It was really affecting their hearing.